I would like to call it augmented intelligence. It's not artificial. It's going to augment us. It's going to help us. The concern comes when AI makes decisions, which it is not ready, and I don't think it will be ready for a long, long time. Most important thing is to explain to them what can go wrong during the intervention, which is important. I think to tell them, yes, I can fix it, probably is inappropriate.
We often talk about technology in medicine, the latest devices, the newest procedures, all the advancements. But what happens when the culture of a place, the way people work together, the standards they set, the example they lead by becomes just as important as the technology itself? Can culture be the real breakthrough? I sat down with Dr. Vinod Nair, an interventional cardiologist here in South Louisiana, and his journey is pretty wild. He came from India in 1990 for residency, landed in the Bronx with no connections, nobody he knew, just a dream. He didn't match into residency at first. He had to live in someone's basement for 6 months, doing some research just to stay in the country. He taught himself computer programming on an old IBM PC while calling doctors to recruit them for his studies. And now, he's been at the Cardiovascular Institute of the South for 22 years, helping develop their entire electronic medical record system from scratch. We got into what it's like working in one of the premier interventional cardiology programs in the country, right here in Houma, Louisiana. He talks about how the culture there is just different, how the senior physicians there, the founders, Dr. Craig Walker, Dr. Tyrone Collins, Dr. Peter Fail, still work harder than anyone else, and how that sets a standard that makes everyone better. How nobody complains about working hard because the people leading charge are right there in the trenches with you. Vinod breaks down what's changed in cardiology over the last 30 years, how we went from just balloons to drug-eluting stents, how intravascular ultrasound is revolutionizing outcomes, but only 10% of procedures in the US use it. He talks about the future of image-guided intervention and why obesity management might be the next frontier in preventing heart disease. But what really stands out for me about our conversation was his belief that experience is experience. Whether it's a nurse, a respiratory therapist, or a cath lab tech who's been doing this for 20 years, if they see or say something, you should listen, because they've seen hundreds of thousands of these cases, and that pattern recognition is real. That's what makes a great team, and that's what makes CIS what it is. Not just the technology, but the people and the culture. And like I mentioned, he helped build the entire EMR system for one of the largest cardiology practices in the region, because apparently being an interventional cardiologist wasn't enough. If any of this resonates, if you've ever wondered what it takes to build something from nothing, if you're curious about what really happens during a heart procedure, or if you just want to hear about someone who refused to give up even when the doors kept closing, you're going to want to hear this one. You can catch the full episode on YouTube or pull it up wherever you listen to podcasts. Search The Last Zebra. All right, let's get into it. Welcome back to another episode of the Last Zebra podcast. I'm your host, Ugo Ezama. As always, please don't forget to like, share, subscribe, and comment. Our next guest is Dr. Vinod Nair, interventional cardiologist that I work with at Terrebonne General, and I have the honor to have him here as our next guest. Thanks so much for coming by.
Well, thank you for having me. I appreciate it.
We've worked together now for about because I'm going into my 5th year as an attending.
That's correct.
Going into my 5th year as an attending. We've been working together now in that time span, and you have a tremendous reputation as a cardiologist, let alone as a physician in Houma and in South Louisiana in general. How did you first get to Houma or Louisiana? How did this all come about?
Sure. I was practicing in Texas, in San Angelo, Texas. I was in a large group there. I was trained as an interventionalist, but did not have much exposure to peripheral intervention. So I was at a conference. I met one of my previous juniors who was working at CIS. So I had signed up for a fellowship at MGA, Massachusetts General, to go do 1 year of peripheral intervention there. And I was told that maybe you should try to do a couple of months at CIS. You will get enough experience. So I reached out to CIS and I was offered a 3 months sabbatical position there. So I came for 3 months. And then 22 years later, I'm still here.
So those 3 months turned into so you never left, you just stayed?
No, I just stayed here. I didn't leave.
It's interesting to me, you mentioned peripheral intervention.
Yeah.
Because whenever I think interventional cardiology, I just assume that is it. Interventional cardiology is just one field. But I remember I spoke to Dr. Finn, who had highlighted all the different sub-specialties that are within cardiology. And now more so, there are a lot of subspecialties within interventional cardiology as well.
That's correct.
So peripheral, what else?
So there is interventional cardiology fellowship, and then you do interventional cardiology fellowship. Then there is structural fellowship, which they mostly do endovascular, like structural aortic valve. And then there's peripheral intervention, which is mostly carotid artery stenosis, aortic stenosis, renal artery stenosis, lower extremity. And obviously then there is electrophysiology, which is just completely different.
Right.
Yeah.
Let's go back. What was your upbringing like? Originally, where are you from? And how did you come to the decision to be a physician in the first place?
So I'm originally from India, one of 4 kids, and my dad was a businessman. My mom is a homemaker. We were born in Calicut, India, with the southern portion of India. And 3 of us, older 3 of us, are physicians, and the youngest one took over my dad's business. It's mostly that's what your parents want you to be back in India.
Is a physician.
Yeah, is a physician or engineer. So yeah, that's how I started out. Not necessarily I wanted to be a physician, to be honest.
Where do you fall amongst the siblings?
3rd one. I have 2 older brother and 1 younger brother.
And so you are the last one to become a physician.
That's correct.
And how then? So you went to medical school in India and everything.
I did my medical school in India, Bangalore, India.
What was that education like compared to what you know about medical education here in the US?
I think it's theoretically much sounder, practically lacking. And for example, you'll see a lot of CT images, but you don't get to do a lot of CT. So you know a lot about angiogram, but you
don't get to actually see it.
Yeah, that's correct. And now things have changed then, and I'm talking about 80s. But now things have changed, it's much advanced, and all these things are available there now. At that time when I was studying, CT, MR and all was just in images that you see in books and textbooks, yeah.
What are your brothers? What kind of physicians are they?
My oldest brother is an interventional radiologist. My second older brother, just next to me, is a neurologist.
Are they all here?
No, they are all back in India. I'm the only one here.
Oh, wow. How long have you been here in the United States?
I've been here since 1990.
Oh.
Yeah. So I didn't practice there. I as soon as I finished, I came here for residency.
Oh, where'd you do residency?
New York Medical College.
That's which borough is that in?
So that's in Bronx. Yeah, that's a little bit upstate. Yeah, the main hospital is called Our Lady of Mercy Medical Center in Bronx.
What was that transition like for you, coming from home to the Bronx?
Yeah, it's a shock from a small town, and yeah.
Yeah, New York can be daunting for almost anyone, and you're coming from a small town in India.
Yeah.
Did you have any prior connections in New York at all?
Nobody.
Wow.
Yeah.
Wow. So you did your residency there. How did you decide to even do internal medicine in the first place versus amongst all the other specialties that you could have done?
So where I was doing my medical college in India, I had a friend who used to be a engineer in California, and he came back to India to do medicine. And so you could go to in a college in India and do medicine if you're a foreign medical graduate. And his idea was to reapply and come back to the United States as a physician. So that's how I got introduced to ECFMG or USMLE. I didn't know anything about it at the time. So I kind of studied with him, and he had these books, Kaplan courses. I don't know whether you know. Yeah,
I have a few back there.
Yeah, so I saw him reading one day in the library. I had no intention of coming here per se. So, and then we got to be friends, and we both studied together and went to write the exam together in Singapore because India did not have facility to write ECFMG. So we flew to Singapore, wrote the exam together, and
wow.
Yeah.
I feel like a lot of things that international medical graduates have to do to get here gets often overlooked. I'm an international medical graduate myself. Yeah. I went to a Caribbean medical school. And so the first 2 years you do your basic sciences. I went to St. Matthew's University in the Cayman Islands, which was a tremendous, great island to be in. But I had the first 2 years basic sciences there, and then did my clinicals in different locations in the United States. Clinically, at least I had some consistency because my school was trying to get us into residencies here.
Yeah.
Clinically, when you came here now for residency, did you find it challenging, or what was most challenging about being because your first time being a doctor was here?
That's correct.
So what was most challenging about that? What kind of expectations did you have that wasn't realized or was not what you expected?
So for me, language was a big problem because I had a difficult time understanding what the nurses were telling me. I had to really listen close. I had an accent. I still do have an accent. So they had difficulty understanding me. So that was one hurdle to cross. And then I think residency was really tough for me because it was, at that time, there was no strict rules on when you can go home and stuff like that. So we would come at 6:30 on one day, and next day you don't leave until 12 noon or 1 o'clock because you have to
sign out
and round and stuff like that. So it was really difficult. So that first year and a half was kind of difficult for that,
What was the thought process when you were navigating? Now you're in internal medicine. When you're navigating all of the subspecialties in internal medicine that brought you to cardiology in the first place?
So I always wanted to be a cardiologist back in India. So, I always wanted to be, I liked cardiology during my rotation in medical school.
I see.
So I really wanted to be a cardiologist. And when I finished and I applied for cardiology, and I got cardiology fellowship where I was, but I needed to convert my visa. I was on an exchange visitor visa, J1.
Yeah, that's what I was on.
Yeah,
I came on a J1.
Yeah, I was on a J1. So then this opportunity of taking fellowship at that program or converting J1 came up. So, and I decided, my roommate, his name is Prasad, he's currently a gastroenterologist in New Jersey. He decided to choose a path of getting, going and converting the visa, and he got a job somewhere in Alabama.
Okay.
So I decided not to go for fellowship, instead convert the visa.
J1.
Yeah, J1. So I came to Texas, Uvalde, Texas. I was there for 4 years. I worked as a primary care physician in a small government health facility.
So, but the dream was always to go into cardiology.
Yeah, absolutely. Yeah.
What is it about the heart that draws you to it?
I think if you really look at cardiology, you'll see there are a lot of Indian physicians in cardiology. This is something back in India that is ingrained in us, that we should become a cardiologist.
Also, cardiology there's a certain
that is
thing about it that is attractive to Indians in general.
That's correct.
Interesting.
Yeah.
I never thought. I do know quite a few Indian cardiologists. I guess I never made that connection that perhaps.
Yeah, there is something.
What do you think it is?
I don't know. There is something about cardiology that they tend to want to be cardiologists.
That's interesting.
Yeah. And I like cardiology. I worked as an internist, and that even more and more I really missed. Cardiology. It's like internal medicine is vast, and I have a lot of respect for internal medicine because there are a lot of gray areas.
Right.
There's really no clear cut. In cardiology, there's a lot of clear cut guidelines as to what you should do next.
Right.
It's kind of a clean specialty in that respect, and obviously you can specialize. And I was interested in interventional. Through the fellowship, I was interested in interventional cardiology. I wanted to be an interventionalist. When I was in Texas at Uvalde, when I finished my 4 years and I got converted to H-1B visa, so I applied so did my friend. He applied for GI. He wanted to be GI from
the one in Alabama.
And I applied for cardiology. And then got interview and accepted interview. I got the position of match when I interviewed in Brooklyn, New York.
So you went back to New York then?
I went back to New York.
Same program?
No, different program. I was in Bronx. Now I came to Brooklyn.
Brooklyn, of course. And what was different from being... I give a lot of credit to anyone that leaves the comfort of a secure job to go back to school or training, right? Because there's a drop in pay, naturally. There is a drop in respect as well. I would make that case, right? So you go from attending to being somebody's, trainee, and it understandably.
Yeah.
And so I went through the entire process right through. And I just know that had I stopped,
it'll be difficult.
It would have been very difficult. Was it your passion for cardiology that just kind of allowed you to overcome even if you had any reservations about that?
No, I did not have any reservations. I was afraid I would not get into fellowship.
Because of the time you'd been away from...
being away, and most of the programs would not like somebody who spent 4 years as in internal medicine to come back to going to cardiology fellowship, as opposed to fresh graduates. Your chances are better.
Right.
Yeah.
And fresh graduates tend to also be much more, because programs like, especially academic programs, like things like research and
that's correct.
Stuff like that. So fresh graduates are much more inclined to have that on their resume than if you had been working.
That's correct.
This entire time. Was your experience as a fellow different?
Yes, very different.
How so?
Because I think obviously the work is not as difficult as an intern or a second year resident. So I think fellowship program was very good. We had 6 fellows in that program, a Long Island College program, and and the chief of cardiology there, Dr. Saki, is extremely nice, and so we had a great time. Those 3 years passed very fast, and really enjoyed it.
When did you? How long have you been practicing now? So my question was really going to be, when did you graduate from fellowship?
I graduated fellowship 2000. I graduated from cardiology fellowship, and I did 1 year additional interventional cardiology fellowship at Maimonides Medical Center. Yeah, so I went. It's like in Brooklyn, but it's one of the highest volume centers in New York. So I did my interventional cardiology fellowship. That's in 2001. I graduated and I came back to Texas in the same town that I was an internist. My intention was to Uvalde. My intention was to come back there and practice there, and they did not have a cardiologist.
Was it something about that town that drew you back to it?
Yeah, because I had made friends there. I made friends. There was a couple of internists were my friends, and they also wanted me to come back. So I decided that would be a good thing to do. But it's probably not the right thing to do because they did not have a real... I'm an interventionalist, and they did not have a cath lab. So I had to travel to San Antonio, which is a good 70 miles to do case once a week, and that didn't really pan out well.
Oh, did that inform your decision to head down this way because you wanted to do more interventional?
No, that made a decision to move to a practice in Texas where I could do only interventional cardiology.
Gotcha. Because that's what you really wanted to do.
Yeah, I wanted to do full-time interventional cardiology. And I got such a fellowship, such a job in San Angelo, Texas, which is further away, West Texas. So I was there for around 4.5 years, mostly intervention. Like I work one day in the clinic, rest of the time in the cath lab.
You've been an interventionalist now for almost 3 decades, or towards going on 3 decades.
Yes.
What has changed in that time span about how we understand or what we understand about the heart?
A lot. Yeah, a lot. As it pertains to interventional cardiology or cardiology?
Both?
Yeah. Cardiology, whole bunch, statins, heart failure treatment, management of heart failure has significantly changed. Mortality has decreased. Interventional cardiology, type of equipments that we have now, we could not even imagine then. And the type of complex cases that we do now, it was probably not. There used to be a time when they did not have stent. Obviously, I did not have to practice during that time, but
for stents,
drug-eluting stents, without stent, they just do balloon and hope for the best. Yeah. So in the late 80s and early 90s and all, there was no. There were no stents.
I didn't realize stents were that new or relatively that new.
Yeah, it's relatively new. In the 80s, in the early 80s, there's usually mostly balloon angioplasty. Some of our physicians who are with us now, like Dr. Fail and Dr. Aben and all, they have practiced in times in which they only had balloon angioplasty.
Wow.
Yeah.
And so stents came about when you were in training?
Just before I was in training, yeah.
I see. And that has been essentially revolutionized the way we take care of...
That's correct. That's very true.
Because percutaneous interventions, you think about stents primarily.
We think about stents primarily. There are people who have been dealing with just ballooning it and then, having dissection and leaving. So they have much more tolerance to leave certain things. I mean, people like me were trained in the era of stents, we always look for perfection, but there are doctors who have been, who have worked and seen a lot of imperfection and still patients get through. So that's a big change. And type of stents have changed. From what we have to current generation stents are very thin. Restenosis rate is very low. And technology has changed to get through chronic total occlusions, and high-risk PCI has significantly changed over the course of last few years. Last few years, especially last decade, 10 years, made big difference.
What's been the biggest difference, or what has impressed you the most about what you were doing 10 years ago versus what you're doing now?
Equipments. Again, there are type of devices that will help us to go further. An example would be something called guide extension catheters. These are extensions that you are able to extend past the guide into the coronary arteries, deep into the coronary arteries. If you have difficulty delivering a stent, for example, you can now use this guide extension catheters to extend the guide into the mid artery or distal artery and then deliver the stent there. Earlier, we were not able to do that. Different types of atherectomy devices, like rotational atherectomy, that was there for some time. The new devices have come out called orbital atherectomy, a whole slew of devices which can ablate lesions, allowing you to deploy stents. And if you deploy stents among a lot of calcium, they tend to have poor patency rate. They tend to have higher subacute stent thrombosis. So that's been replaced by the fact of modifying calcium before you deploy and preparing the vessel before you deploy. And now that field is still evolving. There's a lot changing every day, but I think we are in a much better place dealing with calcium today than just 5 years ago.
Right.
You have different balloons, shockwave balloon, which are lithotripsy balloon, the same things that they use in the urologist. Yeah. So we are able to crack calcium before we deploy stents using lithotripsy balloon.
Is that within the same procedure you're doing this?
Yeah. The same procedure, like, you go in, you find a lot of calcium, you cannot expand a balloon in there. Then you are able to either ablate it with a rotational atherectomy or a device, or go with one of these shockwave balloons. And those balloons, now second generation balloons are coming out. First generation balloons are good, but they're a little bit bulky. Now a new one we're going to get in 2 weeks are much more flexible, has much more ablating power, lithotripsy power. So,
what's something about the intervention that you make for, say, myocardial infarctions, heart attacks, that people generally misunderstand? What's something that usually comes up when you're explaining what you're going to do for a patient in that patient population, that they have a misunderstanding of the most common one that people bring up?
The most common thing that I can see, they think we leave the balloon inside the heart. They say, okay, so when you tell them you take the balloon out, they're kind of a little bit confused. How is that artery staying open then? And we have to tell them so concept of stent is not there. And how we deliver a stent, it's mounted on a balloon, and we inflate the balloon with the stent inside the artery. So those are the things that they have difficulty understanding. So usually we do dilate the blockage with the balloon, and then go in with the stent, which is mounted on a balloon, and then open up the balloon inside the lesion so that the stent stacks onto the artery, and then we deflate the balloon and take it out. So that's a part they have difficulty understanding.
That's fascinating. That's amazing to me. All the same, because these are the arteries you're working with.
2 to 3 millimeters.
That is unbelievable. And so the stents have to be smaller than that to accommodate.
Collapsed stent has to be smaller than that. So we mostly size 1:1 we do intravascular ultrasound to see the size of the vessel and then decide what size stent we need to use. We can go for anywhere from 2 millimeter to around 4.5 millimeter.
You've mentioned the advancements in technology. And of course, you're able to reach further and further into the heart for your interventions. Do you think that technology has made work for physicians or work for providers busier or better, or both?
Not busier. It made life much more easier and definitely better. Improve quality for patients without a question, because every minute we lose there, even on a stable patient who's coming and you have a complication, every minute you lose there is a problem.
Right.
Difficulty getting the patient back. So without a question, quality better for patient, for physician, clearly making the regular procedures easier. But human nature is that we push it to now complex procedure, which we would have never have attempted in the past.
Prior.
So even though the technology is improving, normal patients which are easier to treat now, but we are taking on more complex cases, which we would not have done 10 years ago.
Do you find yourself to be much more forward-thinking in that sense? I think in my experience, I've interacting with older physicians, they tend to be kind of a little bit more dogmatic about their practice, and newer ways, newer technologies might roll out a lot slower for them. Do you find that because of your field being one that is, has to be on the cutting edge, do you lean more easily? Do you buy first or buy into new technology relatively quickly?
I wouldn't say I would buy into, but I probably could to adopt new technology, especially when there is data behind it. Yeah. So I think, especially in the field of intervention, I think there's a lot of advancement happening, and you cannot do the cutting edge most of the time because, depends on where you practice. We're practicing in a community hospital, so you have to be mindful of that. But I think in our case, in our hospital, I think we are probably as good as what we do in New York. I don't think there's much difference when it comes to coronary intervention or peripheral intervention. In case of peripheral intervention, we probably are better because Terrebonne probably started peripheral intervention much before most of the places. When I was training in 2000 in Brooklyn, they were not doing anything close to what Dr. Walker and Dr. Stagg, those physicians were doing here. Some of these things they invented.
Wow. Wow. What was that like coming into a setup like CIS? What I look at it as just this very impressive entity, the Cardiovascular Institute of the South, that is essentially the governing body or the not governing body, but the standard for where cardiology is here in South Louisiana. What was it like coming into a setup like that?
Yeah, it's very impressive, and that's one of the reasons I stayed here. And it's not just I wanted to learn peripheral, but I started out, but I kind of moved away from it, and I went mostly into coronaries. I hardly do any peripheral. I'll give it to people who are interested in peripheral. But I think the very forward thinking, and I practiced in 3 other places before coming here. If you show aptitude, they're all for. CIS is all for you going that route, and nobody has ever told me you cannot do this or you cannot do that. You have to just show you're interested in and trained in it, and so I think it is important, and that's one of the most important reasons I stayed over in HOMA, because I think practice is very well run. They're extremely forward thinking, and cath lab is one of the best I've worked in. And I worked in Beth Israel in New York and Maimonides, Long Island College. I think I would say our cath lab is probably one of the best.
There's something to be said about that being in Houma, Louisiana.
That's correct.
That one of the premier interventional cardiology programs you can find around is there. And I that's something to take tremendous pride in.
Well, that's very true. And I think our community is lucky for that. And I think, hospital is lucky for that. I think there's something to, and it's not just physicians though, to be honest. I think the crew there, some of them has been there for 20 years, 25 years, and they are excellent. And, coming to do an high-risk case or coming to do acute case at night, as the youngest, when I first came, I knew coming to this cath lab to do an acute is not a problem, because the level of understanding about the crew is so high that you somehow become a better doctor automatically. When it comes to intervention, you automatically become a much better physician, skill-wise, because they can guide you. Even now, I've been here for 22 years, close to. I'll listen to, if one of the staff members says something about what I'm doing, I'll listen to them, because I know they've seen hundreds of thousands of these. I'm sure, in your field also, you will see there are some techs.
Respiratory therapists, nurses. One of my guiding principles about the way my worldview on medicine is that experience is experience.
That's right.
So a nurse that's been doing this for 20, 30 years, if she says something, you should probably pay attention to that.
That's very true.
And the same applies to any other, like respiratory therapist, any other field. And I'm saying respiratory therapist because, of course, that's what I'm familiar with. Nurse practitioners, PAs, if they see it.
Sure.
They see it. And I think experience informs that gut feeling. When you're just like, something isn't right.
That's correct.
Something is off. I can't pinpoint it, but I've seen this before. And I like, something tells me that this is the path it's going on. And they have that. The people that have seen all of these cases, seen all of these patients, and experienced how all of them have gone in different ways, and can, because it's pattern recognition, right?
This is correct. It is exactly correct. And I think there is something to be said about it. And I think my decision to stay in HOMA is mostly, obviously, CIS as a group is extremely progressive. They're not just medicine in many respects. Dr. Walker, I'm kind of blessed to work with whom I consider as real great mentors, not one. I mean, Dr. Walker, Dr. Aben, Dr. Fail, they're like, a different level. And even at this point, some of them work harder than me.
I see them every day.
I know.
It's really impressive what they do. You're included in that, at least for me, I guess, as the next generation down at Terrebonne. I'm so impressed at the endeavor that you and your colleagues have shown.
But I'm at that level because I'm encouraged to be like that. It's not because, obviously I have to put my attempt and hone my skills, but every discussion that we have is about what we can do better. And it's never about, okay, you should back off or you should limit this. No, it's always about, have you tried this? Can you do that? So I think the environment plays a lot. And I've been in other situations in which it's about a job. You go home at 5 o'clock. That's never been the case. Even today, I'm sitting and talking to Dr. Abin about a case as to, what would be the next step. And I think that sort of communication, I think it's a whole lot. And cath lab participates in it. And eventually patient benefits, but I think if you ask me one best thing about being in HOMA, for me, is it's just the discussion and how I can develop, how I can become better when it comes to, and everybody encouraging it. And it's not just me, like Dr. Finn, Dr. Shane, all of them have their own part that they are really passionate about.
Right.
And
that's awesome.
It doesn't sound like a competition between us. It's like we would like to.
Comrade, it is a lot of, it's collegial.
That's correct.
And everyone understands that the team is pulling forward towards improving patients' lives.
That's correct.
I find that is actually very rare in medicine amongst.
That's correct.
Why do you think that is?
I don't know. I really don't know. I think that cohesiveness is not there. It's like, I am going to do this or I am. That's not the case here for whatever reason. And it's hard to explain it, but that's the truth. It's,
I've always felt like the actual culture of South Louisiana is very different from the culture of other places in the United States. And I wonder if that informs.
Probably. I think it does not take. I think my gut feeling is that it is the senior most doctors who set the culture, and they are the rate limiting. If they are limiting, I think that kind of trickles down. At this, nobody complains about working hard at CIS, because if you look at Dr. Walker or Dr. Avin, Dr. Phil, they're still performing peak. They probably do more than I do. So I think that is, if I have to pick one reason, that is it. All people who are most senior most and founders and who started this practice, they're kind of instilled such a sort of discipline that people, and it only attracts certain type of people then, not like, when a new person comes here, it only attracts certain type of people who would want to work like that.
Right. So they've set a really high standard.
That's correct.
And so when they ask you to do that, they're not asking you to do something they wouldn't do themselves.
They're not even asking. It's implied. It's not like, nobody has ever asked me in the last 22 years, like, can you do...
Right.
But that is more. And you don't feel like you have to, I don't think like that. It's just like a part of what you do.
I love that because it really shows, I think, it's a great example of what leadership really is.
That's correct.
Leadership is, you set the example and you're asking people to do things without asking, right? Like you're saying, you're doing things that you wouldn't ask somebody else, to do.
Yeah. Or
you wouldn't ask them, you are the example that you want people to follow.
They empower you to do it.
Exactly.
And another thing is that it's well run. I'm not specifically talking about CIS. I'm just saying, in general, I do mostly the things as a physician I should do. I'm not doing a bunch of stuff like work that I'm, not supposed to be doing.
Right.
So kind of they cue it up in such a way that you're mostly practicing medicine. You're really taking care of patients, not necessarily doing paperwork and signing a bunch of letters and stuff like that. They delegate that to people, and so that I can work where I'm supposed to be, my peak performance, which is intervention, I should be able to do as many interventions as I want and take care of that, hone my skills.
Let's go back to interventional cardiology. What do you think is going to be the biggest breakthrough in the next 5 to 10 years?
In coronary intervention, I'll start with that. In coronary intervention, the biggest breakthrough would be imaging. So there's a lot of data out now saying that intravascular ultrasound guided stenting is significantly reduces, improves quality, decreases MACE, major adverse cardiac events, and improves survival. So with IVUS, you are able to see after you deploy a stent, it looks good on an angiogram, but when you do ultrasound, around 50 to 60% of the physicians again go back and do something else.
Really?
You optimize further, because if the stent is not well expanded, there's high. Now we have dimensions which are very cut off. Say if your minimal luminal area is less than this, there's a high likelihood of restenosis.
Interesting.
Yeah, which you on an angiogram it may look excellent, but if you use IVUS, you can now optimize it. Unfortunately, most of the studies comparing bypass surgery with angioplasty, IVUS utilization has been extremely low, in single digits. Yeah. So because IVUS was not, intravascular imaging in general, not just IVUS, OCT, optical coherent tomography is another imaging modality. Or intravascular imaging was very low. In the United States, it's very low.
Even now,
it's probably around 10%.
Despite the data that supports it.
Yeah, there are many reasons for it. Despite the data this data is new. This is what's going to change, hopefully, in the next 10 years. Is that first of all, the device is costly. It is not being reimbursed. Most of the insurance does not reimburse the device. So there is an immediate cost issue there. You're already using stents and stuff like that. So there's a cost issue. But it's kind of reimbursed okay now. It's almost a pass-through now. So I think more devices that in complex procedures, most of my cases, I do 100% of the time intravascular ultrasound guided intervention. I think that's going to change. And there's a belief that if you can do IVUS guided or imaging guided intervention and then compare it to other modalities like bypass, it will be better.
Right.
So if you have to choose one device to improve a stent or improve mortality, improve morbidity, would be intravascular imaging.
I don't think I made that connection before about the use of intravascular ultrasound, especially because we get those patients, your patients, a good bit of them into the ICU. And I do see IVUS quite a bit.
Yeah.
And I think in my mind, because that's what I was familiar with, I just assumed that was part of standard of care.
No. I hope it'll become standard of care, but in the US it is not. In Europe, they do probably more than us, but I think we have a long way to go. So in 5 years, I think it's going to make a big splash and probably push more physicians to use IVUS and optimize stenting.
As a cardiologist, and certainly as an interventional cardiologist, and one that for sure deals with patients who are, or sees patients who are higher risk, that being by and far, I think, just from watching you work, that seems to be a lot of your patients tend to be ones that are difficult and challenging. I'm sure because and I'll give you an example. We shared a patient that couldn't get the standard treatment for his coronary artery disease. He had more than triple vessel disease, had a CABG or was evaluated for CABG, but couldn't get it for reasons.
Sure.
And when I spoke to him, he was so deflated. He was so deflated about, he felt like now he got a sense of an acute timer about, impending doom, essentially. And you obviously consulted, because that's the story here, and you were able to do some interventions that gave him some hope. And I don't know if you probably won't even remember it, because I'm sure a lot of these stories might be what you're experiencing. But having seen that in his particular case, and when you're meeting patients that feel that loss of hope, how do you connect with them and give them the impetus to, let's try that again?
Sure. So, a couple of things. I think those patients, it's very easy to tell them you do have a other option. Now, we would first refer a patient to surgery for certain specific reasons: diabetic, proximal disease, left main disease. That's basically, in nowadays, most of the things we fix it with balloon and stent, and there is no data that surgery is superior to intervention. The proximal LAD, left main, diabetic. These are the three cases where where Lima can give an advantage. Other than that, there's really no data.
Right.
So in those patients, if surgery is turned down because the patient is high risk, then you have two options: continue medical therapy, which is not a bad, to be honest, the current medical therapy is not bad, unless the patient is really decompensated and having heart failure. It's not bad. That option should always be there. But most of them, knowing that they have such bad blockage, choose to go with intervention. So I don't think convincing them or telling them, giving them hope is not the problem. The most important thing is to explain to them what can go wrong during the intervention, which is important. I think to tell them, yes, I can fix it, probably is inappropriate. The right thing to tell them would be, this can be done. Normal cases, just quote, chance of complication is 1%. If you go choose this path, it's probably around 4 to 6% or some percentage. I think that's important to convey to them. Most of them would say, I'll think about it, but eventually they would go, majority would want to proceed with it, because nobody wants to know that they have 80-90% blockage and have heart failure and walk around with it. But the more important thing is to explain to them that what the data shows is, especially left main cases, that if you go, now if the surgery is an option, some patients choose intervention even with the surgery being option.
Also, there are cases where both options are available.
Yes. And surgeons would say, yes, I can do it, but you have X percentage of stroke risk or whatever. And then they will come to us and we'll tell them. And they still choose, some of them still choose, especially older people who don't want
to go through the
cabbage.
Exactly.
Yeah. So, but then we need to clearly explain that what the data shows there is that over the next 5 years or 6 years, if you take a less upfront downtime with intervention, but you're a diabetic and it's a left main case, we do a special type of procedures, 2-stent strategy and all. They tend to require more procedures over the next 5 years or 6 years, multiple 1 or 2 more interventions. But mortality is the same. There's no really difference in mortality in the 5 or 10 years, but you may require more repeated intervention, number one. Number two, and more important thing is that need to understand and we need to gauge the risk of them not being on dual antiplatelet therapy. And that is probably the biggest risk, which I see, is not the technical success. Technical success we can predict. Predicting when somebody would need to stop dual antiplatelet therapy because of bleeding, or whether they have finances to continue with, they are compliant with medication. That would be the biggest risk. In my opinion, once you agree with, they go with intervention. Bypass surgery, you don't really have that risk of worrying. You want to stop aspirin for 5 days, 6 months into it. That's not a big problem as opposed to drug-eluting stents.
again, doing high risk percutaneous intervention, there are a lot of it's high stakes essentially. You mentioned the risk and percentage of risk compared to standard therapy. How do you carry that weight? And how do you carry that weight? And how have you been able to navigate through all of that in the last 30 years? Over the last 30 years.
Yeah, I didn't do this many high risk for that last 8-9 years. I've mostly good 50-60% of practices high risk PCI. I think there's bad outcomes always kind of weigh you down. You know, how many over years you've been doing it. For me, what helps me is I spend a good 40 minutes in the initial consultation with them. I don't spare any details. I would make sure they come with family and they don't come alone. And I tell them not to answer today. I don't want you to say yes or no. I want you to think about it and let me know. So they, and I feel better, you know, and I've seen the patient report is better if and when a complication occurs, ability to kind of, for them to understand and make sense of what happens. I think it's them to know they had a choice. Look, I can be treated with medications. I don't really need to go with this high-risk PCI. So I think that's one way. Then talking to, if you had a negative, and I have had my shares of having a supportive group is very helpful to kind of bounce off, and talk about it. And cath lab crew is important. You know, we sometimes go back and look at things and see why things didn't work. What was the problem? If you think of it as a learning opportunity, and, you know, you're going out of your way to ensure there won't be complication. There will be complications. You're doing devices that spinning at 180,000 RPMs. You're going to make some complications sometime.
With all of the advancements in treatment options and therapeutics, do you feel like we're pulling away from preventative measures and what we can do for that?
No, I don't think so. Well, my opinion, I'm biased. So I think we have quality data at CIS. We clearly know what percentage of individual mind and system-wide, clinic-wide percentage of patients are appropriated for. We follow 6 major diseases in cardiology: heart failure, CAD, PAD, atrial fibrillation, dyslipidemia, hypertension. We clearly know our stats as to how many of these patients are appropriately treated, both primary prevention and secondary prevention. And we sort of delegate, even though we see a lot of patients, we have a team looking at it on a near real-time basis. For example, all the patients who are outliers today that I've seen are adjudicated tomorrow by a nursing team. We have a software which will do analytics and spit out both outliers, physicians and patients. So 1,200 to 1,300 patients a day is seen across CIS a day, of which around 200 would be captured the next day as outliers.
Wow.
And they are addressed in that day. For example, somebody left the clinic with blood pressure of 160 by 90, and that was not addressed. Next appointment in 6 months, it's all ACC guidelines recommends such patients medication should be adjusted or home blood pressure monitoring be maintained and re-seen in the clinic within 30 days. So somebody is monitoring that, and they are empowered to call the patient, reschedule appointment, talk to the physician, make the change, and bring the patient down.
Wow, that's amazing.
Yeah, so I think, so what I'm trying to say is that I don't believe we skimp on quality. I think we monitor quality well, and we are able to do that with the use of software, with the use of allied staff who can help us with that.
I'm always impressed at any institution that is able to have that kind of holistic health system that, because it's data driven feedback.
Yeah.
That's pretty impressive for anyone, let alone to look back at where the errors are happening, where the outliers are, And being able to address that immediately is pretty impressive.
Yeah, and we are able to do it because individually I won't be able to do it.
It's a lot.
I'm today in the cath lab. I don't have time to go and look at what I missed yesterday.
Right.
And it's not that I miss it. So the missing part comes like this: patient is coming to me with chest discomfort or claudication pain, and I'm addressing that claudication pain that day.
Right.
But the patient is not on aldactone for congestive heart failure. He should have been on aldactone for congestive heart failure. But my attention and the time I have is limited to why the patient came.
Right.
But that is a fallout regardless. But that is picked up. That is adjudicated. And that's taken care of by a group of RNs and LPNs who would, if they want to call me, they will call me. But majority of the time, we have written guidelines as to how that needs to be done. Not prescribing medications, but like if the patient's blood pressure need to be controlled and there is no standing order, they're going to send me a message and say, look, what can we do about this patient? So we make changes right then.
Are these measures CIS directed, or are they coming from, granted, there are things that are mandated essentially, if you will, by health bodies and boards. Sure. Are these metrics specifically?
Yes, specifically CIS mandated.
Wow.
So these are American College of Cardiology guidelines, but CIS picks and chooses the ones which are of interest to. We have a medical practice committee and a quality committee, which reviews these and kind of allows the nursing staff to delegate certain responsibility to them, so that you don't have to call the physician and ask his opinion. If we discharge somebody with high blood pressure and there's no follow-up visit, you take care, you do it. Nobody is going to question. You can do it. I think you have to do that. Otherwise, waiting for a physician to answer the message back, that just is a roadblock.
Right.
So no, these are all, it originates at the quality committee and it goes to MPC, Medical Practice Committee, for final approval.
Amazing. What's one thing that people can do, or something that you think is not done enough that could help the general public in heart health?
I think now would be management of obesity. I think we do have a clinic, but I think we should. It's mostly limited by inability to get those medications.
Right.
But I think with the data that is out there now, especially with cardiovascular mortality and morbidity, I think that's something that can be done more. If that price can be somehow brought down a little bit more.
One of your calls to fame, if you will, is that you helped develop the EMR.
That's correct. Yeah.
Yeah, the EMR for CIS.
Yeah.
Can you tell me a little bit about that story, that journey, and what that was like?
So when I first got, I have been interested in computer programming since 1990. So when I first came here, I didn't even know what a computer was. So when I first came here, I did not match. I applied I got 13 interviews and nobody offered me. Wow. So I had, my visa was valid for another 6 months and I had an option to either go back to India or reapply, and I was afraid to do that. So I found a colleague, not a colleague, as a cardiologist. I used to come from my town back in India. So he kind of invited me to his house and said, look, I'm doing a research project called CADI trial. It's called Coronary Artery Disease in Asian Indians trial. I want somebody to, obviously I cannot work. I want somebody to help me. I did not have money to stay for 6 months. They said, if you help me with this trial, you can just room and board here.
Oh.
Yeah. And he said, and I know this guy, this professor at New York Medical College, I can talk to him and see July, if possible for you to get to residence. That's how I got
into that residency.
Yeah.
Because you were exposed to them and they knew about you.
Yeah. And they were friends. And then I stayed with him. His name is Dr. Inas. He's a he was practicing cardiologist at that time in Chicago. So I stayed in his basement, and he gave me his job. He was running a study. He's a lipidologist. He's into lipids, and his intention was he wanted to study Asian Indians. We have like very high incidence of coronary artery disease. Asian Indians.
I didn't know that.
Yeah, we have smaller caliber coronary arteries and higher incidence of diabetes. This drives premature coronary artery disease in Asian Indians. So he was doing the study, and he wanted somebody. There was an upcoming meeting called AAPI, American Association of Physicians from India, and this meeting had 25,000 registered doctors across U.S. and Canada. So my job was to call these doctors at their home and ask them whether they would be willing to give a sample of blood when they come for this annual meeting. That was my job. So I was relatively no work until 5 p.m. and I have to call them after 5 p.m. Do I make sense? When they come home.
Yeah.
So I was in the basement, and he would go to his office, and so he had this IBM PC there. It's like an 808. It's a very old PC. And he wanted me to make a database. So we went to a local store, and bought a database called Paradox. You probably don't know this. This is not existing anymore. Yeah. So anyway, I had this book, and then, so he would leave. So I would just read. There's nothing else to do there. Okay. So I would read this book, and so I kind of got interested in computer programming at that time. So since 1990, I've been, programming in computers, and then when I came to CIS, during my fellowship, I wrote a small program to read echocardiogram reports that fellows used. Yeah. And then when I came to CIS had we have a large research department, and they were looking for somebody they were looking for a software that they can capture research data. So we did I was in the committee, we did some search. We couldn't find a software. So then I kind of asked them, the then CEO, would he mind if I develop
the software?
Yeah, the software. And initially they didn't say anything. So what we did is I just went and developed the software as much as I can. And one day we called him, myself, and I don't know whether he predates you, Gary Sherson. He used to be the director of the cath lab. So we developed this software, and then we invited the CEO to see this. It was an echo program, and he saw that, and he said, "Oh, when can you deliver it?" So then we started a company called Objective Medical System, and it's separate from CIS, and nothing to do with CIS. So we developed the diagnostic. It started out with one diagnostic module, which is Echo. What it does, it captures the data from the machine, and it generates the report. And it saves all the discrete data on a database. So now we have 17 different modules. Echo, nuclear, CT, like
all
that.
The things.
Yeah, all the things. Across everything that CIS does is fully automated through this. And then around 2011, when this EHR meaningful use came up, and this time around they asked me, would we be interested in doing EHR for us? And we have 3 years to go. So I was saying that I took 6 months off. I worked every other week. And CIS allowed that, you go by and then 2015, we released the EHR.
Did you feel any sort of, pressure?
Yes, I did. So I underestimated what is involved in the EHR. If I knew really what was maybe I would have declined the offer, but I underestimated. And some of the things in life, great things happen because you underestimate it.
So absolutely.
I underestimated. But it's now, obviously EHR needs certification. So now there are 3 certifications. Now this is the stage 3 certified EHR. And specifically for cardiology, we don't cater to anything else. So good thing about it is that we are fine-tuned with the cardiology workflow and is tightly integrated with the diagnostic studies. We can compare and contrast. And everything is stored as discrete data. We don't have PDF files or single file. Everything in the EHR is a discrete data element. So each time you ask for a report, it's generating the report from a database.
Got you.
So there's no finalized report. Finalization is a field in the database saying signed. So good thing about it is that we don't need to pre-specify any data elements that we need to research on. So if you suddenly say we would like to go back last 10 years and find out a patient who matched just this demographic criteria, ejection fraction of 35%, not on an ICD, it's a minute's job to get that data.
It gets it sorted almost immediately.
Yeah, so that's a good thing. So that thing is locked. The downside of that is intensive CPU utilization. It requires a lot of processing,
right?
Which is not a big problem because that can be solved. That's finances. But I think the good thing about it is that we can do unlimited amount of clinical decision support rules. We currently trigger 18 checks on every patient who comes to the clinic. And some of them, these 18 checks are mandatory. You cannot move past. You just need to answer yes or no, and it automatically. So if you're patient not on a beta blocker, the physician just needs to say yes. And practice committee has approved a beta blocker to be the one to be started, which is based on evidence.
Right.
For heart failure, and it will automatically fill that in, and then it's e-prescribed. So kind of efficiency optimization. It took exactly 7 days. So we were going from a paper chart to electronic. It took us 7 days to get to the same level of efficiency at the paper chart level to EHR level.
7 days from going live.
Yeah.
Wow.
So, I always say, since it is we can afford to do that because we don't need to cater vaccinations and a whole bunch of stuff that is not particularly important for cardiology. Unlike like an Epic has to cater to whole sorts of different specialties and stuff like that. So we are focused on cardiology. So it's kind of easy, even though it's certified as a general EHR. But in general, it won't be a good pulmonary EHR. It'll be a good cardiology EHR.
Would you guys ever? Are you still a separate entity?
Yeah, it's just a completely separate. We just license it to CIS. Everything is
interesting.
So the entire CIS is running on diagnostics, EHR. We have an analytics platform called Trace Analytics, which also CIS licensed. We have a remote patient monitoring platform called C3, Chronic Care. That is a diagnostic at Terrebonne General is OMS. So the diagnostic report that you see generate, and if you look in the bottom, it'll say it'll compare. It'll even compare with an echocardiogram, which is done at Terrebonne with any echocardiogram across CIS.
That's amazing.
Yeah. So like if the EF went down, you will see that ejection fraction at CIS was this. It could be anywhere in CIS. It could be in Illinois CIS. It will compare and contrast. That's because we store it as discrete data.
That's amazing. Would you ever consider, are you still making decisions for OMS such that would you ever consider expanding it beyond?
Yeah, we are currently doing it. We were very busy with, we have 5 things, EHR diagnostic, remote patient monitoring, which is like, we collect blood pressure or body weight remotely and video communication, telehealth. And then we have quality, trace analytics, and now we have an AI platform for the last 2 years. Yeah,
that's what I wanted to ask you. I mean, how, being that you're so experienced in software engineering, software production, what is your what are your thoughts on artificial intelligence and how it's going to impact healthcare, especially coming from your background? Having a good understanding of what that arena is like?
I think there'll be a lot of consolidation. I think in net it will be positive. I'm sure there are going to be some hiccups, some mistakes made, but I think net positive. I don't think it is. I would like to call it augmented intelligence. It's not artificial. It's going to augment us. It's going to help us. That ought to be the way we think, as opposed to the concern comes when AI makes decisions, which it is not ready, and I don't think it will be ready for a long, long time. But to augment us, help us make a decision, I think it is. Which it already does, for example, in oncology, breast cancer especially, I think a majority of them, normals are read by, Stanford, the normals are read by AI, abnormal is reviewed by
a human.
So which kind of decreases your cognitive workload or amount of effort you need to put. I think that ought to be the way it goes. And obviously, normal need to be verified, and FDA has to have some role in it and strict guideline as to what they approve, which is the route they are going now.
Right.
But I think there will be some mistakes made, but you have to be careful when it comes to clinical. There are 3 levels of how AI can affect healthcare. One is, of course, clinical. That's what you and me think. Then there is operational efficiency. Okay, I can give you an example. Like we have no-shows at CIS. We have around 10 to 12% patients don't come up. And the downstream revenue loss for a cardiology practice for a patient not showing is around $600 per patient. So imagine 200 patients a day. That's a whole lot of money. And not just the money, it's really eating away resources that could have been used by a patient who's waiting to be seen by the cardiologist or any physician.
It leaves a clinic spot not used.
That's correct.
Is a clinic spot that has been wasted, essentially.
Wasted, but you're paying for the resources.
Right.
Nurses are there, doctors are waiting, the electricity is running, whatever.
Right.
So we could have used that. A patient not coming for a nuclear test is a significant loss because you have a nuclear material ready for that patient, which is extremely costly, and the patient is not there.
Right.
Yeah. So so we already do that. We can predict with around 80% certainty which patient would not come for this appointment 48 hours ahead. So we do this at CIS. We are able to run a list, and the system will pick up high-risk patients who won't come for this appointment. And it automatically sends messages to those patients alone and asking them, are you going to come? And if they say no, it'll forward it to the front office so they can reschedule it 2 days ahead. So that is operational. And next is workflow efficiency. So you have clinical, operational, workflow. An example of workflow efficiency would be like a patient has an appointment at 10 o'clock. Physician is running late. Now, AI could contact that patient and say, you have an appointment at 10 o'clock. Would you like me to be notified 20 minutes before he's ready because he's running late? Now, that running late is dependent on the physician and the type of patients the physician has between this appointment and the real patient's appointment.
Right.
That varies. And it's a pattern. It's not a math. It's not 2 patients equal to 30 minutes.
Right.
It's based on patient complexity. So AI is excellent in it. AI can do that very good. And if the patient answers yes, it can predict 20 minutes ahead, saying that, okay, you can be coming. So that will be an example of, operational efficiency. So there's a 3 levels. So operational and workflow are probably what is in the next 2 to 3 years. They're the place where AI is really going to shine in medicine, with more input from FDA and regulate. This thing don't need FDA approval, but more input from FDA and regulatory bodies. I think clinical will get there. No, clinical already there are many like your watch, that the ability for it to diagnose atrial fibrillation. I think this is huge, and we see 2 or 3 patients a month solely because of that. And most of the time, when it comes to AFib, it's accurate.
Really?
Yeah, it is accurate. It's very accurate when it comes to when it's diagnosing atrial fibrillation.
I'm never taking my watch off then.
No. So stuff like that, I think we're doing one clinical now, which we are going through an FDA
approval.
Not approval. We are getting an expert from FDA to recommend us how to go about, because what they require is not just the proof how you got the answer. They require to see the process how you went getting this. It's not, they don't just look at okay, let's see 10 patients. Yeah, they would really like your solid reasoning how you got there. So what we're looking at is looking at an EKG to diagnose whether the patient has diastolic dysfunction, systolic dysfunction, and approximate ejection fraction.
From the EKG?
Yeah, without doing an echocardiogram. And validate, we already have hundreds of thousands of EKG.
Right.
So we're currently training with 20,000 EKGs with diastolic dysfunction and 20,000 with no diastolic dysfunction, and letting it, and then same with echo and EF. So that's something that we have just started, but it'll take some time. But we are really heavily focusing on operational and administrative efficiency. Scanning documents is an example.
Right,
At CIS, we scan approximately 500,000 pages in a week into the system. And this has to be somebody manually doing it, looking at the patient and putting into the chart and manually putting into the section of the chart. We're working on something which is in production now. We can bulk feed it, say from Terrebonne sensors, a whole bunch of it, and it can then scan it, recognize which patient it is, date of birth, match the patient, identify what type of, we have 12 type of document coming from a hospital, identify what type of document it is, and obviously it can do it up to 80%, 20% it cannot, and that's 20% you show the human, and that the other 80% it should be able to file
to get
them.
it.
And you should know certain type of documents need to be seen by the physician before you file. For example, if it is an echocardiogram report, I may want to see it before you file it. So you have rules built in it, which is able to then decide which way it should go. So we are at the early phase of testing that right now. It's in production.
These are the things that I would classify this like an AI agent, essentially.
That's correct. It's an AI agent, exactly. It is doing a job that it is trained to do. Wow.
What do you do outside of work? What are some things that interest you outside of work?
Nothing. I like computer programming, as I told you. I spend most of the weekends programming.
Programming non-medical things, or is it still centered around?
Centered around medicine, but I like computer programming, so I spend a lot of time.
Interesting.
Not necessarily I'm developing something, but I just learn or new things or read new things.
If you couldn't be who you are today, so if you couldn't be a cardiologist, an interventional cardiologist, or computer programmer on the side, what is there a passion that may have been long gone now, and you might still have it, of something that you would have gotten into beyond medicine, beyond computers?
When I was in India, I wanted to be a diplomat. I wanted to go out of India as they have a section called IFS, Indian Foreign Service. So I always wanted to go out.
Like, is it in a way like travel, or are you not able to do that now? You don't think?
Oh, I can. I can travel. Yeah, but you asked me. I don't have any other. I'm glad I'm a physician, even though it was not my choice. I'm glad my dad made the choice, but I like it. I really thoroughly enjoy being a physician, and I'm very happy that I'm able to marry these two, computer science and medicine.
Are you interested in cricket and No. You are probably the first Indian.
I'm not into any sports.
I asked that because growing up in Jamaica, West Indies, cricket is along with football, so soccer. Cricket is one of the major sports that we grew up playing. I don't play it at all here now, but that's definitely something that I got into growing up in Jamaica as well. Dr. Nair, thank you so much.
You're very welcome.
This was very enlightening.
Thank you for having me. Appreciate it.
Absolutely.
Thank you so much for joining us today. If this conversation resonated with you, there's a lot more where that came from. We've got stories from healthcare providers, healers, innovators of various industries, and people doing work that truly matters, each one bringing something very different to the table. Feel free to check out another episode and subscribe so you don't miss what's next. And if you know someone who would enjoy or needs to hear this, share it with them as well. I'm Ugo Ezema, and this is The Last Zebra. I'll see you on the next one.